Well, it was a great honor to be asked. It was a huge honor for me in that I know that the Santa Fe, the individuals, the members of the Santa Fe are some of the brightest people in our profession, in healthcare profession. And actually, when I was at the University of Minnesota, I was there at the same time that Dr. M.S.D was there. And I didn't know much about him then, but what I did know was that he was an extremely brilliant man. Everybody at the university knew that Dr. M.S.D was brilliant. So fast forwarding 25 years, I find myself in the Santa Fe group with another group of brilliant leaders in the profession. So it is a great honor to be part of it and to be asked to be the fellow. It proved to be this year so enriching to be surrounded by these people that are so honorable, who do what they do for no other reason than just advancing our profession, for pushing, raising the bar, pushing the card, and just making our profession a better one, having us work better with our medical and social service colleagues, and ultimately for improving the outcomes of those that we serve. So it's very simple, and it is just a wonderful place to be. Well, it really was a whole team. Okay, so I might have been there who listened to all pieces of it from the players and said, okay, now let's put together the action plan. Let's bring together those people who are the best in the field, the best educators, trainers, those who are major stakeholders. Okay? And how are we going to get them to come here? So the easy part was, because of the reputation of the Santa Fe group, okay, that acting as a neutral convener, that we called people and they were delighted. They got this call and immediately said, count me in. Right? So it was, and that happened because of who the Santa Fe group are. So now we bring the best together, charging them with, we have this problem in our profession. Show us what you are doing. Demonstrate your best practice, because amongst us, we identified those who we believe were the leaders, who we believed had the best practices out there, okay? Who we believe were the more important people to get their ear, okay? Who we believed that were working in, who our medical counterparts were, who were interested in the oral health messaging for the geriatrics. Bring them together and see what we can come up with in a day and a half. Our government has spent a lot of money, billions of dollars in Y-and-Y programming, so addressing the needs of HIV populations. And these there's been an evolution of those with HIV disease, but largely people who are medically complex, disenfranchised, uninsured or underinsured, and really perceived as challenging to the medical profession, and which is including here our dental profession. I mean, our dental profession had many, many issues when it came to HIV disease in the late 80s, early 90s. We put together programs that effectively trained dental care professionals. We were, with all of the oral lesions that were associated with HIV, we had no choice but to be working with our medical colleagues. Okay? Our medical colleagues actually needed us in the early 90s. They did not know how to handle fulminating lesions in the oral cavity. Okay? So we had the opportunity in the early 90s to step up and become full partners in terms of primary care management for the HIV patients. Okay? So now I look at the senior population and see so many of the parallel issues happening. Okay? Again, we have an opportunity to be fully integrated into the primary care team, fully integrated. There are issues there are leading issues, many issues in terms of increased cancer and caries issues, xerostomia that are perplexing to the medical professionals that they actually need us to assist them with. They have a 70 million. Many of the patients have cognitive disabilities. We can assist. We are needed. Yet we have here too trained a cadre of health professionals that are as uncomfortable treating our senior population as they were with patients with HIV disease. Okay? Different discomforts, okay? The contagion issue isn't there. The disease transmission issue isn't there, but they're still uncomfortable. There's the medically complicated issues. There is
medication.
Yeah, the side effects of the drugs. And we are continuing to turn out healthcare professionals that will tell you that their level of comfort isn't what it should be. And this is not good in new healthcare professionals. I already think the meeting is a success. So what do we have to demonstrate here? At the very minimum, we talk about putting together a toolkit. We should be able to assemble and disseminate the best practices that are out there. We should be able to say to healthcare professionals, all healthcare professionals, that if they need information on developing a training for a physician or a nurse, if they're in a dental school and they've been charged with putting together courses or even a course or a lecture, they should not have to hunt for where this material is. If they are looking for advocacy messaging to nurses and physicians and consumers on why oral health in the senior population is important, it should be readily accessible. The contents of a curriculum should be easy to reach. And right now I don't believe that's the case. Okay, I think it's out there, but it is not put together and it's not easily managed. Okay? So that's what I think we can achieve as one outcome. The others, I hope that these individuals will make suggestions for demonstration projects. I hope that we will be able to come up with some ideas on how we can develop a cadre of leaders. Every school, if a school doesn't have a leader in geriatrics and senior health, then the students suffer. Okay? So how do we take faculty development? We heard speakers talking about this and really target it to let's develop faculty who may be interested in this, but need to be given the time and the resources and the mentors so that they can flourish. And then their school flourishes, their students flourish, and the patients will too.